Good afternoon, everyone. Greetings from Mumbai, India. My brief today is to tell about how to repair an intraoperative injury to the abductor mechanism. At the outset, I'd like to thank my dear friend Oliver for giving me this opportunity to be part of the SECOT conference at Madrid. My name is Vaibhav Bagaria. I work as the Director of Orthopedics at the Sir H. N. Reliance Foundation Hospital in Mumbai, India. Before we begin our talk about how to repair the abductor mechanism, it is important to understand the anatomy of the abductor mechanism. The abductor muscle group primarily consists of three muscles: gluteus medius, gluteus minimus, and also tensor fasciae lata. The whole complex is a mix of these three things. It is supplied by the superior gluteal nerve, primarily from the L4-S1 contribution. The nerve exits the pelvic superior to the piriformis in the greater sciatic notch and runs in the gluteus medius fascia approximately 5 cm proximal to the greater trochanter. Now, the causes of abductor mechanism failures or injuries is usually multifactorial. Primarily, these could be surgical approach related, wherein a direct lateral approach with improper retraction may be the cause of the tear. Often, the GT fractures happen because of the inappropriate cut and migration of the saw. Of course, patient related factors like osteoporosis and degeneration in abductor tendons also plays a role. When this happens, it is important to understand the gravity of the situation. Primarily, two things. One, whether it is a bony abductor disruption or it's a soft tissue disruption, and what is the extent of damage. There are different ways to look at it. I found this classification system simple and intuitive. The simplest type will have an abductor detachment from greater trochanter with no tearing of the conjoined tendons between the abductors and vastus lateralis. Type 2 will be a partial abductor tear less than 50% or more than 50%. Type 3 is a complete tendon tear with viable muscle, and 3B is a complete tendon tear without viable muscle. And finally, the type 4, which is basically the bony fractures of greater trochanter, which is repairable, and B, which is non-repairable. Now, this is quite extensive classification, but in reality, if we look, we could have a longitudinal tears which involve just a direct repair. So there is a rent in the gluteus medius, and if you could just stitch it just the way we have shown in the picture, that will suffice. The second commonest tear is a U-shaped tear in which there is almost a rim of the gluteus medius that gets detached, and in this we have to attach it to the bone by drilling a hole in the greater trochanter with a K-wire or a 2.5 drill, multiple holes, and then attaching the tendon in this fashion to the bone directly. Now, sometimes the tear could be massive, and in this case, we have to augment. So, if you look here, there is a clear rent, and the quality of tissue is very poor. In this case, what we have done is we have augmented it with the gluteus maximus and the TFL. And in the next illustration, we'll show you how this has been done. So, if you look here, the Gmax has been pulled up, and so has been the TFL. A small nick is made. The rent that is created because of this tear is stitched, but they are advanced and used to buttress the defect. Often that's the only way when you have a very poor tendon quality. Now, coming to the most common disruption, which are the greater trochanter fractures. In the cases of greater trochanter fracture, we have the option of a screw or cable fixation. We can use K-wire and TBW. We can plate and graft, bone graft, autologous. Usually, if you have a fracture, you can get it from the femoral head itself, or otherwise an allograft with a BMP is an option when you are dealing with an osteoporotic and comminuted fracture. Let's look at this case of a failed IT fracture. You can clearly see that there is an abductor mechanism disruption here. This is the CT scan, so you can clearly look that not only the fracture is bad, but also the nature of the bone, the comminution, and the osteoporosis is quite significant. You have got very multi-fragmented thing. Now, when we look at such a fracture, we have to look at various options that we have, and of course, the option is whether to plate or fix this abductor mechanism with TBW. So this is a simple thing where you are doing TBW. We know that the TBW converts the tensile forces into the compressive forces, and it's invaluable tool in the armamentarium. Similarly, if there is comminution and lot of osteoporosis, then we use a plate like a hook plate, and you can also do bone grafting. So what we did in this case is we used a combination of both. So you'll see this is how we put a plate. This is a specific plate. We held the reduction. We use this plate. This is often used. I like this plate specifically because this is actually meant for plating. Use a lateral plate when there is a lateral wall fracture, along with when you have an intertrochanteric fracture for PFN with a lateral plate plating. You'll see a big hole there to allow the screws of the PFN nail to go through. But I like this plate because it allows us to bone graft. So once this plating is done, you have reasonably stabilized the greater trochanter fracture. Then you can also add or augment it with a TBW. So I'm passing this underneath the gluteus medius tendon here, and you'll see that we pass a TBW wire here, again underneath the shaft, and then figure of 8 fashion. You'll see that I have made a figure of 8 here, and the crucial thing is tensioning, and appropriate tensioning is one that is most important here. It should be appropriate tension, and then it should be cut to the length. Once you have done that, you can bury the knot there, and this is how the final X-ray looks like. You can see the amount of comminution that was there in this case. So we have tried to engage as much of bone as we could and plate to stabilize this comminuted fracture. Now the patient is almost 4 months walking from the day 1. The post-operative protocol, of course, was with weight bearing restriction. We gave a protected weight bearing with a frame. We progressively started the strengthening of abductor muscle, and of course we are following it with regular radiographic X-rays. To conclude, we must look at the preventive strategies. In patients who have got severe osteoporosis, a preoperative DEXA scan should be done. It is important to handle soft tissues in appropriate manner, and our choice of surgical approach is also crucial to prevent any abductor mechanism disruption. Intraoperatively, if you have a fracture or a disruption, it is important to identify it on a timely basis. It has to be both visual and tactile. If the tear is small, it can be directly repaired with non-absorbable sutures. But if it is a large tear in soft tissue, one should consider augmentation with TFL and GMAX advancement. For a plain transverse greater trochanter fractures, which is non-comminuted and the bone stock is good, KY TBW fixation is appropriate. Whereas for comminuted and poor quality bone, a plate with or without bone graft with augmentation of TBW is required. And with that, I'll thank you for your attention and welcome any questions that you have. That's my hospital in Mumbai, where I work, with a motto respect for life and traditional Indian way of doing namaste. So namaste to everyone from Mumbai to Madrid. Thank you.